Let's jump right into this exhaustive explainer on intracranial arachnoid cysts. You're here because you want the complete, unfiltered clinical picture without having to dig through a heavy textbook yourself, right? Well, you're in the right place. We are going to meticulously break down every single diagnostic criteria, surgical warning, and outcome detail. No skipping the important stuff today, so let's get straight to it.
Here's our clinical roadmap for today. We'll be evaluating the cysts, tackling the classic treat versus monitor dilemma, diving into surgical options, managing those tricky suprasellar cysts, and wrapping up with expected patient outcomes.
All right, Section 1, Evaluating Arachnoid Cysts. Let's look at how we actually pinpoint these things using our go-to imaging tools. So when you're evaluating a patient, a CT scan or an MRI is usually going to give you exactly what you need. A CT scan is fantastic for confirming the chronic nature of the cyst. Why? Because you can clearly see the nearby bone expanding and remodeling. It's undeniable. But if you want the gold standard, an MRI is really your MVP. It is way better at definitively proving the fluid inside is just cerebrospinal fluid, rather than fluid from a nasty neoplastic tumor. Plus, it gives you a gorgeous view of the actual cyst walls.
If you are looking at a CT scan, you're hunting for a very specific profile. You want to see a smooth-bordered mass sitting outside the brain tissue, so extraparenchymal, and it should absolutely not light up with IV contrast. Now here's a crucial detail. These cysts very often trigger ventriculomegaly. We're talking 64% of supratentorial cases and a whopping 80% of infratentorial cases. That's a massive correlation.
Like real estate, it's all about location, right? Location entirely dictates the mass effect, setting off a direct chain reaction inside the skull. If you've got a cyst in the convexity or the middle fossa, it's going to push directly inward on the adjacent brain tissue. It compresses the ipsilateral lateral ventricle, the one on the exact same side, and that inward pressure, that's exactly what causes a distinct, very noticeable midline shift. Now flip the script. If that cyst is located in the midline, posterior fossa, suprasellar region, or at the quadrigeminal plate, you've got a completely different and frankly far more serious problem on your hands. These guys compress the third and fourth ventricles. By physically blocking critical CSF pathways like the foramina of Monroe or the Sylvian aqueduct, they are directly causing hydrocephalus. Every now and then, CT and MRI leave us scratching our heads with tricky midline lesions. When that happens, we might bust out flow studies like cysternograms or ventriculograms. We inject tracers or iodinated contrast to see if the fluid actually moves into the cyst. But honestly, the results can be incredibly variable. Since some of these cysts act like tiny pouches or diverticula, they only fill up sporadically. Okay, moving to Section 2. To treat or monitor. We've found the cyst. Now comes the real clinical headache. Do we jump into the OR, or do we just sit back and watch? Here is the golden rule, and it's absolutely crucial to remember, because, let's be real, seeing a huge mass on a scan makes everyone want to act immediately. But many authors explicitly recommend not treating an arachnoid cyst if it isn't causing symptoms. Size doesn't matter here. Location doesn't matter. If the patient is completely asymptomatic, just leave it alone. Instead of rushing to scrub in for an incidentally discovered cyst, we stick to a very strict wait-and-see timeline. For an adult, bringing them back for one single follow-up scan in 6 to 8 months is usually all you need to rule out dangerous growth or developing ventriculomegaly. But for pediatric patients, that's a much longer game. They need to be monitored meticulously, tracking them all the way into adulthood just to make absolutely sure no symptoms sneak up on them over time. Section 3. Surgical treatment options. Let's say symptoms do pop up, or that 6-month scan shows some scary growth. We need to look at our surgical arsenal. We have a few very distinct surgical pathways we can take, and we need to weigh them carefully. Let's break down the major pros and cons point by point so you have this totally locked in. First up on the list, simple drainage. We're talking needle aspiration or a burr hole. The upside, it's incredibly fast and easy. The huge downside, the recurrence rate is notoriously high, for both the cyst returning and the neurologic deficits coming right back with it. On the total opposite end, you could choose to shunt the cyst. Now this gives you a definitive low recurrence fix, but you're saddling your patient with lifelong shunt dependency and the ever-present anxiety of a foreign body infection. Then we have craniotomy and endoscopic fenestration. These are great because they let you actually get in there and directly inspect the cyst. It's especially effective for treating rare loculated or multi-compartment cysts. And best of all, no permanent shunt. But the risks are no joke. Post-op scarring can easily block up your beautiful fenestration, causing the fluid to build right back up. Plus, abruptly decompressing the brain carries some really significant morbidity and mortality risks. Now, if you do decide shunting is the way to go, there is a highly specific surgical caveat you absolutely have to memorize. If you're placing a distal shunt from the middle fossa, you must route that tube securely behind the ear. You have to completely avoid anterior tunneling. Why? Because you risk devastating injury to the facial nerve. Seriously, if you somehow have no choice but to go anterior, the literature strongly suggests calling in a plastic surgeon to help completely protect that nerve. It's that critical.
All right, Section 4, Managing Suprasellar Cysts. These specific midline cysts throw some totally unique anatomical challenges at us and demand very specific protocols.
Because of where they sit, suprasellar cysts need specialized approaches, like a transcallosal cystectomy. But if you're looking for the procedure of choice, championed heavily by Pierre Kahn and his colleagues, you're looking at a percutaneous ventriculocystostomy. You meticulously perform this through a paramedian coronal burr hole navigating straight through the lateral ventricle and the foramen of Monro. And you'll often use a ventriculoscope to get that perfect precision.
I really want to hit pause here and highlight a massive warning straight from the clinical literature. If you're dealing with a suprasellar cyst, attempting a subfrontal approach for fenestration or removal is universally considered highly dangerous and utterly ineffective. Just don't do it.
And here's another strict warning. Do not try routine ventricular drainage for these patients either. It flat out does not work, and worse, it actually promotes the cyst getting even larger. Avoid it at all costs.
Which brings us to our final stop today. Section 5, Expected Patient Outcomes. We have to face the reality of post-operative life. Because the truth is, even a technically flawless, textbook-perfect surgery doesn't just magically reset the patient to perfect anatomy. The treatment is really just chapter 1 in managing the permanent neurological footprint this cyst leaves behind.
Let's look at the facts. Even after a brilliant procedure, the brain's environment is permanently altered. A portion of the cyst is almost always going to remain, largely because the bone remodeling and the chronic shift of the brain contents are permanent. On top of that, hydrocephalus can still sneak up and develop long after treatment. And those tricky suprasellar cysts, they often leave patients battling lifelong hormonal imbalances or endocrinopathies.
So, considering these permanent anatomical shifts and those lingering functional issues, we have to ask ourselves something pretty profound. Is the surgical extraction of an arachnoid cyst really the end of the disease, or is it merely the beginning of a lifelong clinical relationship with your patient? Thank you for walking through this detailed explainer with me. Keep reviewing this material, and I'll see you in the next one.